Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Gerd. It's an acronym for Gastroesophageal reflux disease. What is it? Well, it occurs when the stomach acid flows back into the tube that connects your mouth to your stomach, the esophagus. And the lining of your esophagus is more delicate than the lining of your stomach, so the acid in your esophagus causes a burning sensation in your chest, and that's GERD.
Why does it happen? That's what we want to know, and what can be done to treat it. Joining us in studio is Mayo Clinic gastroenterologist and GERD expert, Dr. Jeffrey Alexander. Welcome back to the program.
Thank you. Glad to be here.
Gastroenterologist, that in itself is a long word. What does it mean? What do you do?
It's a good question. What do I do? But we study the gastrointestinal tract, which usually goes from the mouth through the stomach, the small bowel, the large bowel, and then out the rectum. So we cover the whole gamut.
And a lot of you subspecialize, and you're kind of a GERD guy, GERD expert, right?
Yes, I kind of specialize in the esophagus, which deals with GERD.
And tell us what GERD is. I sort of tried to explain it to our audience, but what is it in your terminology?
Well, GERD is gastroesophageal reflux disease, which is there's a muscle at the bottom of the esophagus that sort of works like a one-way valve. It allows the food to go down, it then stays closed and stops the acid from the stomach coming back up into the esophagus. Now, everyone refluxes through that valve a little bit. But if you reflux more through that valve, get more acid in the esophagus, then that may cause damage to the esophagus. It may cause a symptom of heartburn, which is kind of a burning sensation under the breastbone, or it may cause a symptom of regurgitation, where there's a liquid sensation of material from the stomach coming up into the chest or even into the mouth.
So the terms heartburn, acid reflux, and GERD are often used interchangeably, but they're not the same, are they?
Not the same. You know, GERD is this occurring that's causing symptoms. Heartburn is the symptom of burning under the breastbone. Regurgitation is the symptom of liquids coming back toward the mouth. In gastroesophageal reflux disease is if someone has one of those symptoms significantly affecting the quality of their life.
So it's an umbrella term? Is that what you would kind of call it?
Okay. Well, the symptoms of GERD are heartburn and regurgitation.
Gotcha.
And can't those symptoms be confused with a heart problem?
No,
a heart attack?
Absolutely. That the classic hallmark symptom is burning under the breastbone, but it could be pressure, it could be a nauseated sensation, it could just be a generalized discomfort, very similar to the symptoms people can get with a heart attack. And sometimes it can be very difficult to distinguish the two.
Okay, we said so heartburn is one of the symptoms of GERD. And heartburn, explain what is heartburn? Yeah,
heartburn is a sensation under the breastbone of a burning feeling. Frequently it occurs after meals. Sometimes it occurs after spicy foods, tomato-based foods, chocolate, spearmint, peppermint. Can occur after big meals and lying down, can occur after alcohol. That's the hallmark symptom of gastroesophageal reflux.
So the lying down is why more people would experience it at night than during the day.
Yeah, frequently if that muscle's not working so well and you lie down, then the esophagus and the stomach are at the same level and the acid can slide up. And it's not uncommon for people with a bad valve to develop heartburn symptoms at night particularly if they overeat and go to bed.
And so the issue is that the stomach can tolerate acid, and the acid is in the stomach to aid digestion and digest our food. But if that acid gets back up into the esophagus, it causes pain. The esophagus doesn't like acid.
Esophagus doesn't like acid.
All right. And what about causes?
Well, causes are generally a weakness of the muscle, okay, or increased pressure on the abdomen. If you gain weight, a lot of weight is increased pressure on the abdomen, kind of pushes in the stomach and kind of stresses that valve. So overeating certain foods, ones we talked about, can have some effect on that muscle. Caffeine, nicotine, alcohol are big factors, but the major factors probably are a weak muscle, exacerbated by overeating, big meals and lying down.
And what about obesity? Aren't they people who are obese more likely to have it? And pregnant women?
Absolutely, yes. Obesity in pregnant women, there's more pressure on their belly, which kind of just pushes things back upwards. through that valve back up in the esophagus. And yeah, those are certainly risk factors. Very common for pregnant women to have reflux, and the hormones have an effect there too, but often it's just a effect of the weight of the fetus on the abdomen.
And do some people just have a weak muscle?
Yes.
That's called the lower esophageal sphincter, right?
Lower esophageal sphincter, and people can have a hiatal hernia where there is some separation of the diaphragm, which is where the sphincter, the esophagus goes through the diaphragm into the stomach, and if that weakens, that can take away some of the strength of that muscle per se. So when a layperson may say I have a hiatal hernia, well, hiatal hernia is some of the stomach coming up in the esophagus, which may or may not be associated with reflux. However, if you do have a large hiatal hernia, it does make that muscle function weaker and is more likely to be associated with gastroesophageal reflux.
Are there some medications that can make it more likely that you'll have reflux?
There are medications, anticholinergic medications particularly, but
that would be like what kind of medication? What are anticholinergics?
Something you use for the bowel, like Levsin or Levbid, or anticholinergics can be seen with a multitude of medications, cardiac medications and others, but they're really not major players. Theophylline can do it, but they're not major players. And I think that the major players are the obesity, overeating, lying down.
And what about why is this of concern? I mean, what are the potential complications of having acid in the lower end of your esophagus?
Yeah, good point. I mean, the things we worry about are biggest concern is development of Barrett's esophagus, which is a result. The esophagus kind of transforms to look more like stomach tissue as a result of reflux injury. The only reason we really care about that is that does have an increased risk of esophageal cancer. Now, so reflux is in long-term reflux is probably the major risk factor for esophageal cancer. Now, that being said, esophageal cancer is not that common in the country, but it's our big concern to evaluate this. Also, reflux can cause damage to the esophagus, which can cause bleeding, and it can cause narrowing of the esophagus or a stricture, so that when people eat food, it gets stuck on the way down. But the real big concern is this rising incidence of esophageal cancer.
So you really want to keep the acid in the stomach.
That's a good plan. Yeah.
And how about diagnosis? Can you, by talking to someone, pretty much make the diagnosis, or are there tests that you do to confirm that they have reflux?
Yeah, I think that I'd like to think I can talk to you and make a diagnosis pretty consistently.
Probably as long as you've been doing it.
I've been doing this 30 years, but if I look at scientific evidence, I'm not better, maybe 50%, but I think probably closer to 75%, but not perfect. So the gist is that if someone has very typical symptoms, I think we frequently make the diagnosis by clinically talking to the patient and may try them on a diagnostic treatment trial. But often we end up requiring to do tests to make the diagnosis, particularly if people with more resistant disease or people who are going to be on long-term therapy or people who are planning on doing some sort of surgical procedure. We really want to be sure we have the right diagnosis.
Do you ever have to go down there and take a look?
Yeah, the test we can do is we can look with a scope called an upper endoscopy. And if you have severe damage to the esophagus, that makes the diagnosis. But often people don't, and we have to do pH testing, which is a couple different techniques that we can. One is a probe through the nose, and one is a probe we just stick in the esophagus at the time of endoscopy with nothing out the nose. And those measure acid for 24, 48, or 72 hours, depending on the technique, and allows us then to determine how much acid is in the esophagus. Normally, it should be less than 4%, certainly definitely less than 6%. And it can also help us to determine over that 48-hour period when Mr. Smith developed chest pain, he pushes a button. And I can go back and look and say, okay, over that 24-hour period, number one, was there an abnormal amount of acid in his esophagus? And number two, when he pushed the button for his pain, did that or did that not correlate with acid up in his esophagus? And that really helps us in the management of this disease.
All right, so Barrett's esophagus is when the acid comes up into the esophagus, and it causes an increased incidence of cancer of the esophagus. And Barrett was a doctor, I assume, and he described this condition?
Yes, he described it. He was actually not exactly right with what he said, but it turned out that he
got his name on it.
Got the name on the paper, and he brought attention to this area.
All right, our guest is Gerd expert, Mayo Clinic gastroenterologist, Dr. Jeffrey Alexander. It's time for a short break. When we come back, we'll talk about treatment options for Gerd. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives. I'm Dr. Tom Shives.
And I'm Tracy McCray.
Our guest is Gerd expert, gastroenterologist, Dr. Jeffrey Alexander. We've talked about the symptoms of Gerd, we've talked about the causes, and we've talked about the complications. And now we want to talk about the treatment. And I know that there are several options that are available. And what's first on your list? How do you first attack the problem in most patients?
Yeah, I think that some things, if it's very simple, it may just be lifestyle modifications, which generally are don't overeat, frequent small meals, don't eat within 3 hours of going to bed, don't exercise right after eating, and sleep with the bed elevated if you have symptoms at night. That may take care of a lot of people. And
so before you even get to over-the-counter medications, those are some things that you should try.
Yeah, I think so. I mean, depending on the severity of the symptoms. But
Sure.
for infrequent symptoms, that would be the way to go. And then take something kind of on an as-needed basis. Antacids such as Maalox or Tums, they will bind up the acid in the esophagus, work quickly within a couple minutes. They don't last very long, but they can relieve symptoms for the occasional symptoms. Then there are other over-the-counter medications, H2 blockers such as Zantac, Ranitidine, or Pepcid, which is famotidine. Those are acid blockers that last longer, 8 to 12 hours, and those can kind of be taken if someone has a bout. If you have a kind of a bout of hot reflux and it's very rare, it's not unreasonable to take an antacid at that time and take a Pepcid pill. The antacid will kind of work very quickly. Its effect will dissipate in a half hour, whereas the Pepcid may kick in a half hour and last for the next 8 hours to get you through the rest of the night.
So doing both of them is okay? Doing one that's instant and one that's long-lasting?
Absolutely, yeah.
How do you know when you've gotten too much, you've gotten to rely on over-the-counter medications too much?
Yeah, it's if you're having symptoms, more than occasionally, once a week, I think is probably, everyone's got a different criteria for what's too
Sure.
much. The medical literature suggests 2 or 3 times a week. I think that's a little much. If I'm waking up having heartburn once a week, I'm probably going to want to take something to prevent it. So whatever that number may be, once a week is probably enough for me. That I think then you ought to go on something preventatively, a acid blocker for a longer period of time, and take it once a day or twice a day, depending on the compounds, which we can talk about, to prevent the development of acid reflux and the symptoms.
So the prescription medications that are available are the same as the over-counter. They're just stronger, right?
Correct. There are the Ranitidine can come in 75s, and the prescriptions are 150. So generally, the over-the-counters come in variable strengths, but they're generally the same drugs, and the doses can be very adjustable. So
tell us about the recent recall of Ranitidine, brand name Zantac.
Yeah, there was a company in Europe that was found to have contaminant N-nitrosamines, which has kind of been seen in some other drugs, that is a carcinogen. Cancer-causing drug in their compounds. And that was taken off the shelf. And now 2 other companies have just taken their Zantac off the shelf and recalled all the Zantac. It's unclear which preparations this is in, and the actual cancer risk of this is probably very low. But I think the current state of the art would be we have lots of other medications we can use, and I think that we're advising our patients if you have Zantac, just switch to over-the-counter Pepcid.
All right. So we've pretty much covered the medical management and the lifestyle changes that you can do to help with this condition. So let's talk about surgery. Let's say that someone has been on prescription medication as strong as you've got, and they still have a problem. What do you do then?
Yeah, let me just go back a second and talk about the proton pump inhibitors, which are kind of if the H2 blockers, which is Zantac and Pepcid, are a dime, The proton pump inhibitors, which is omeprazole, lansoprazole, prilosec, Nexium, they're a quarter. So they're more potent agents, last longer, and they're probably our mainstay.
Proton pump inhibitors.
Proton pump inhibitors. And you can control people with reflux. Maybe up to half of the people with mild reflux you can control with the H2 blockers, Zantac and Pepcid. The other half are going to need proton pump inhibitors, and the ones that we see are often on the proton pump inhibitors.
What is that medication doing?
It blocks they both block the acid production by the stomach. The H2 blockers block one of the triggers of this proton pump. The proton pump inhibitors block the whole pump. So they are more potent blockers of acid suppression. Blocking acid, then you don't regurgitate you don't make as much acid, you don't reflux as much acid in the esophagus, and generally can lead to healing of the esophagus if there's injury and prevention of symptoms.
But don't they have some side effects, the proton pump inhibitors?
Yeah, they've gotten a lot of press about the side effects, most of which is kind of overblown. That a lot of this is done in retrospective studies, looking back at patient population basis. And the problem there is that we found that proton pump inhibitors are associated with, let's say, a 1.5% increased risk of people taking those, 1.5 risk of a fracture of the bone. Well, and actually, if you look at the studies, it turns out these drugs don't affect the absorption of calcium, and they don't affect the bone density at all. It's just that sicker patients are taking the drugs. The people taking the drugs are more likely to have other comorbidities, other risk factors for these diseases. Particularly, they're often obesity is often a complicating factor. So it's very difficult. Sometimes we think, oh, the drugs showed this, but in reality, it wasn't an effect of the drug. It wasn't really a well-controlled study. It's a result of scientific misadventure to some degree. But nonetheless, there are some risks to the drugs.
All right. I think, like anything.
Yes. And I think if you don't need the drug, you shouldn't take it. If you can be controlled with a lesser drug, you should be on the lesser drug, an H2 blocker. If you don't need that high a dose, go for the lower dose. And a lot of the people on these drugs probably don't need them. So they're safe drugs to take if you need them. And if you don't need them, there are some risks, a little overblown, but there are some risks that are real, and you need to take them appropriately.
All right, so surgery.
Surgery.
Everything else has failed.
Everything else has failed. We're down to surgery. Now, there's our standard surgery is called a Nissen fundoplication, where the surgeon's going to go in laparoscopically, poke a few holes in the belly, put some scopes in, and essentially wrap some muscle around the top of the stomach to recreate that valve, that one-way valve that's failed. And it's a standard procedure, been done for years, works very well. There could be some difficulty swallowing afterwards, some other side effects, but relatively speaking, if you need the operation, it's a good thing to do.
All right, now tell us about that TIF you've got.
TIF, yeah. Now there's a couple endoscopic procedures that we've looked at tests done through a scope to fix this. We've putzed around with things for 20 years. Most of them haven't turned out so well. But there's a couple procedures that look like they've got some staying power and are reasonable. One's called a lynx, which is a magnetic necklace. You can be placed around the esophagus, done surgically, but has less complications than a Nissen. And the other one is a thing called a TIF, which is done endoscopically through a scope through the patient's mouth. We kind of create a valve similar to a Nissen valve. Now, the endoscopic procedure, the TIF, and the lynx don't work as well as the surgery, but they're not bad. 90% of the people will get off their acid-blocking drugs. How long they last? Looks like they last at least 5 years. It's as far as we got the studies out now. So time will tell. But I think we do have, at least now, an endoscopic technique. One's a laparoscopic technique that aren't quite as good as a Nissen, but maybe don't have the side effects of a Nissen, that are something we can consider.
All right, and that sounds pretty good. No incision surgery.
No incision surgery.
All right. Gastroesophageal reflux disease, a common problem caused by frequent acid reflux. Multiple treatments available, over-the-counter medications, prescription medications, and surgery in more severe cases, even a newer procedure that doesn't even require an incision. Our thanks to Mayo Clinic gastroenterologist and Gerd expert, Dr. Jeffrey Alexander. Thanks for being here.
Oh, thanks for having me.